Dr. Andrew Wickline, an opioid-sparing total joint surgeon who is recognized as the highest volume orthopedic surgeon in New York State, questions. You spend 2 hours in the operating room with your patient. What are you doing the other 3,024 hours to optimize their recovery? That's where Upgrade by Mend comes in. If you don't already know what Upgrade by Mend is, it is a pre- and post-care program designed by leading professionals. The program provides patients with remote monitoring, clinical nutrition, and a team of nurses and dietitians acting as an extension of the physician's practice. The program is covered by insurance and is proven to enhance outcomes from your total joint surgery. If you're a clinician and speeding up patient healing time is a priority for you, head over to mend.me to learn more about Mend's digital upgrade program, or please reach out to partners at mend.me. All right, we got a cool episode again. It just amazes me, all the great people that are out there in orthopedics. Actually, what I like to say is we find the most incredible, unique people. They just happen to be orthopedic surgeons. Jovan Laskovski, who's an orthopedic surgeon of Macedonia descent. He's a child of immigrants who has saw the light for orthopedics, became enamored by an orthopedic surgeon, set him on his way, and he is now a master hip arthroscopist, travels the world educating on his new techniques. I love his crossover between the shoulder and the hip, how he's taken rotator cuff things that we now do in the hip as well. Really very passionate, incredibly articulate, is a great person for education on the podium. And really, this is a great conversation. I know you're going to like it. Dr. Scott Sigman, hashtag follow the fro.
From medical media, this is The Ortho Show.
Hello, world. Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon, here for another episode of Ortho Show podcast, where we're bringing you the best of the best in orthopedics. Everyone knows that. Please don't forget to check us out on our YouTube channel so you can see us now talking back and forth. We have an outstanding guest today, Dr. Jovan Laskovski, who's an orthopedic surgeon who specializes in hip preservation as well as shoulder, loves orthobiologics as well. He is the man. He is the dude from Ohio. Jovan, love him. So nice to have you on, brother.
Thanks, Scott. I appreciate it very much. Happy to be on.
Yeah, you got a lot of great stuff that you're doing, which is why we're really excited to bring you on. You sort of live in your own world. You've got this great social media thing that you're doing. You're educating. You're on the podium. You're doing all the great stuff. So we're really thrilled to have you on. But before we get started, I got to ask you a quick question, because we always do our research, and I was checking out your website. It's really cool. Is that you actually hurdling on the website, or is that someone else?
No, I would break both my hips if that was me hurdling. My athletic days are far, far gone now.
There is a slight resemblance of, you got to go back and look at it a little carefully, but I was like, I don't think so, but we better ask. But look, we always start from the beginning, and I know as we led in before we came on, for those that are listeners, you can't see it, but on the YouTube channel, there's a Macedonian warrior in the background over there, just behind Jovan's shoulder. But tell us about where you're born, where's your family from? Are you the first doctor? Where did it all start?
Yeah, so I grew up in Canton, Ohio, as the suit of armor behind me would denote. My parents were both from what at that time was Yugoslavia, but is now Macedonia. So son of two immigrants, really interesting way to grow up. I lived in a house with my grandma and my grandpa, my aunt and uncle and their two kids, and my mom, my dad, and me and my brother. And so it was a very loud, very boisterous house, as you could imagine. We were all talkers. And so you'd walk in at any holiday and you'd think that the roof was blowing off.
So I'm assuming you're bilingual. There had to have been a lot of. So what's the language for Macedonia? I'm terrible. Give it to us.
It's a Slavic derivative. It's Macedonian. My grandmother spoke it to us. My parents spoke it to us, and grandma turns 100 next month.
Wow.
So she's a tough old gal, and she's still with a full deck of cards, which is pretty impressive.
Now, it's funny. Is that part of the blue zone? Is that sort of that the area, because she's living to 100, where it came to mind as far as nutrition and things that they're eating, or does Macedonia fall outside of that?
You know what? I think it's just barely in the blue zone, because I think in terms of latitude, longitude, it's just north of Greece. and their
Sure.
weather is pretty spectacular year round. And, I grew up, she had a huge garden in the back. And so everything we ate came out of that garden, or she made by hand. And I give that up to her for her longevity. Is she made nothing but homemade meals, and that's all she eats to this day.
Oh, I love it. So, all right. So an immigrant family, lots going on, boisterous family. You have no choice. You're going to succeed. You're going to be educated. The next generation is so important. When was it that sort of medicine came to mind for you, that's what the direction you were going?
Yeah, it's interesting because my original path was I wanted to be a history professor and I wanted to play college football. And so, like most of these ortho stories go, I ended up breaking my ankle my junior year. Met a really great orthopedic surgeon by the name of Al Michael, and he was the first doc I met who was just normal. You could have a conversation with this guy. He was hilarious. And so when I healed up, he let me come to the OR for a day, and I was hooked. I go, you can do this job and be normal. And he goes, absolutely, you can. So I completely switched gears. I applied and got into a 6-year combined BSMD program through what's now NeoMed, but then was NeoUCOM. So finished college at 19, finished med school at 23, and then it was off to the races from there.
Wow, that's a rapid program, man. I was looking at you, and I thought that was one of the questions I was going to ask, as far as a 6-year program, because you definitely accelerated through. It's so funny that you said that Dr. Michael was this cool guy. Rick Madsen was the same way. He's like, I was doing the neurosurgery thing in DC, and I was, after 2 years, I was like, I just don't want to do this. He goes to the anesthesiologist. He's like, what specialty should I go into? He's like, you got to go into orthopedic surgery. Those are the guys that are always happy and having a good time. And that was his story. So there you go, 2 in a row, saying the same thing. All right, so you blast through undergrad and medical school in no time. At the age of 23, you're accelerated. It's orthopedics all the way. You were destined for that as soon as you broke your ankle. So so how do you? So talk to us through residency at this point. Now you're in residency in 2007, 2008. Is that about right as far as the timeline?
Yeah, 06 is when I graduated from medical school. So 06 to 2011.
All right. So what's going on in residency in 2006 to 2011? What's exciting? What's the subspecialty? Because it certainly ain't hip arthroscopy yet. That's still in its earliest days. But what was getting you excited back in that time?
Yeah, I'll tell you, the biggest influence that I think I had during residency was Rob Bell. So Rob, as you know, was president of Shoulder and Elbow Society, and I was just blown away the first time I set foot in his OR. And you couldn't go in his OR until you were a 4th year. But when you talk about perfection through the scope, it was unbelievable. Everything he did was effortless, and he took me through every procedure and how to perfect it. And I was hooked. I mean, shoulder was truly my first love, and I was in love with the scope. I mean, growing up in the 80s as a kid, video games were pretty hot, and I was like, I could play video games for the rest of my career and help people doing it. And so I probably pestered Rob way too much. I spent most of my chief year with him and one of my current partners, Kurt Knoll, and I just fell in love with the scope. And the hip thing was just coming on the horizon, but that was more of a fellowship thing.
Yeah, so that's great because it's so funny that there aren't more of you, and so the hip and the shoulder they're kind of they're kind of the same, large volume joints. There's the shape of things is a little different, but there's a lot of similarities in the things that are going on. So it's not unreasonable for the brain to be able to understand both of those spaces, right? The other thing for our listeners, when you think of a joint, most of the time you think of us scoping a joint, but more often than not, what we're doing is outside of the joint. It's in the spaces that are around. So it's interesting. So shoulder was big. That, in 95, 96, when I was finishing my Curl and Joe fellowship, we were scoping, but we weren't really doing anything. But a decade later, there were actually these things called suture anchors, and instruments, so you could pass stuff and actually do something. So you're in that heyday of the development of all these new great things. So shoulder arthroscopy was there for you. All right. So then you decide you're going to do a fellowship. You want to continue to hone your skills. You do your fellowship at the University of Chicago, which is a sports medicine arthroscopy. Give the shout outs. Who's going on there? What's happening at that time?
Yeah. I got a bunch of shout outs. So Bruce Ryder, who obviously founded the fellowship and still writes some amazing stuff for AJSM. Sherwin Ho and Jason Coe, both were my fellowship directors, along with Greg Portland. And it was an amazing year because they were very, very much into innovating and trying to improve upon things, particularly in the hip space. You know, as you said, shoulder at that time, we had instrumentation, we had everything. And fellowship was when I had my first idea for an invention, and that was the reverse cutting hook knife. And I still remember Mark 1. It was this long hook-shaped blade, and I attached it to a drill chuck, and that was Mark 1. And the idea was I could get a grip on it, I could do a capsulotomy safer, and the guys loved it, and they encouraged me to develop and innovate it. But really, the big moment that changed me forever was Dr. Bird came as a visiting professor to the University of Chicago. And he gave a talk for Grand Rounds, and that was it. I was absolutely hooked because everything he showed was effortless, and it looked so easy and smooth. And I go, I'm going to be like him when I grow up one day. So that was a big life-changing moment.
Yeah, so for our listeners, he's one of the founding fathers of hip arthroscopy, right? And but he wasn't, in the earliest days, you were just excited, to get the camera into the joint, right? Like I was working with Joe McCarthy doing hip arthroscopy in 1993 or something like that. We weren't doing anything, but just in that short window of time, things really sort of elevated. And Dr. Bird, so fantastic. So did you do so at that point? Did you go beyond your fellowship? Did you do some extra stuff? I mean, how did you really get good at hip arthroscopy?
Yeah, I mean, I was lucky that I got a lot of volume during fellowship, but again, that hunger for knowledge, it never kind of stopped. It never stopped for me. And so I went and flew down to Mexico City, spent time with Victor Elizolaturi, because he at that time was talking about iliopsoas impingement. He was talking about gluteal tendinopathy, tendonitis, possibly tears. I went and spent time with Brian Kelly at HSS in Manhattan, went and flew out and spent time with Philippon, and the list goes on and on. I mean, anytime I get a chance, if I'm traveling, I can get in an OR with one of my colleagues, I'm there because those little tiny pearls will make you better and better along the way. And the beauty of our little community is it's very collegial, and we're all in it to try and make that a better, experience for both the physicians and the patients.
Yeah, I mean, to have the humility to understand that there's people out there that know more than you do, and then to be able to have the courage to be able to call them up and say, hey, I'd like to spend some time with you. I'm sure Andrew Wickline is an arthroplasty surgeon up in New York. And, Andrew makes a point very similar to what you're saying. Almost every year, he identifies an individual that he thinks is really special, and he makes arrangements to go to their operating room to be able to watch and learn. We should do more of that. I really believe that. We have conferences, we get together, we have talks, and we do all those sorts of things. But it's something else entirely to watch somebody do a procedure live, and to be able to learn those tips and pearls from the experts. So kudos to you for taking all that time and energy. And now, how many hip arthroscopies are you doing a year?
Probably around 650 on average.
That's a lot, dude.
Yeah, but Scott, you got to remember, it's not just FAI labral stuff, right?
Yeah.
So all the extra articular stuff I ended up learning after fellowship. And so there's no way in a town the size of the city of Akron that you're going to be able to find that many labral tears a year. But I'll tell you, gluteal tendon tears is probably about 20% of the general population over age 65. And then the work we've done with hamstring tears, particularly partial tears that get missed a lot on imaging and MRI, that's how you get to that number. Plus, obviously I have the shoulder practice as well. That's another probably 200 shoulders a year that we do.
That's fantastic. So for the listeners, FAI, it's just a term that means like when you're inside the hip joint, the labrum, which is this little cartilage thing, can be torn and things can hurt, and you put the camera in, you debride it. But the problem with that is you got to have really good indications to make sure that the patient's going to do well, right? The number one way in which you get successful outcomes with hip arthroscopy is being specific on who you operate on. But these other things, like, for example, the gluteus tear is like the rotator cuff of the hip. Right? It's a very similar tendon, and it's a very similar way in which you can fix it. And these patients that are 65, they're out playing pickleball now. And, they've been sitting on their chair for 5 years. They get up to go play pickleball. Shocking that they have, injuries, but they can do really well with these extra-articular, repairs and the hamstring tears that you're talking about in athletes as well. So it's fascinating that the space in which you're working and the types of operations that you're working on the hip has really expanded, over time. And so it's a natural transition for the shoulder for you, because it's got to be a very similar feel.
Yeah, I mean, I took all the principles that I learned for rotator cuff tendon repair surgery, and I just applied them to those same two pathologies. Pickleball, it's interesting that you bring up pickleball, because I can tell you I've seen more partial hamstring tears from pickleball than I have any other sport out there. And it's that quick lunge that they go after. But, when you look at gluteal tendon repair, I learned it from Brian Kelly, who's the godfather of that space. And his portals didn't make sense to me. And I go, well, why don't I just do my best to turn this into a rotator cuff tear? So I plan the portals out under fluoro, and literally the residents go, this is just like if I turn my head this way, this is just a giant rotator cuff. And that's what it is. It's unique in its own way, because the tendon tissue quality of the gluteal tendons is much thinner than that of a cuff. And that's kind of how we got into the augmentation space there. But it is such a similar transition, easy transition for a shoulder scope surgeon to make into the hip world. And they could not even do FAI surgery and be facile at both those.
Yeah, and it's going to be interesting. I think that's got to be one of the fastest growing, subspecialties in orthopedics at this point is the world of hip arthroscopy. But yet, how many true hip arthroscopy fellowships are there right now and available?
Very, very few. I mean, the majority, Scott, are going to be sports programs where you get your hip arthroscopy rotation. And one of the reasons I was fortunate enough, I got a month to travel, and I spent a week at each of my top 4 kind of fellowship locations. And I got to see hands-on, basically, you're going to do hip arthroscopy the entire year without a break, because both my fellowship directors did it. And so it was good, because I got the repetition that I needed to become good at it. Because in terms of learning curve, there is no operation higher. You give me 10 cases, Scott, and I'll have you scoping and fixing glute tendons. No question. For labral surgery, it's a completely different ballgame. It's just a technically difficult surgery. But again, there's a lot of us like myself that are out there trying to innovate and make it more accessible so everybody can start, helping folks out that have that problem.
Yeah, no, I mean, I think that first of all, there's a problem that's been identified. And, it's so funny with pickleball, I got to bring it up. I'm going to let you operate on all the tendon tears that are up there. But man, ortho laser, we're crushing it when it comes to pickleball, because all those mid-substance muscle strains and bruises and all that stuff, that's perfect for laser. We're actually sponsoring pickleball, the professional pickleball tournaments now across the country with ortho laser, because we feel so upside on the use of laser for those types of things. So, kudos to you for sort of developing and really sort of innovating in this space as well. Let's talk a little bit about that. What's your relationship with industry? You started innovating very early on in your career, and you must be doing a lot of that now. How does that work for you?
Yeah, I loved your podcast with Parvizi because it was really interesting to see how he came up with his own way to help surgeons innovate. So I was involved with a surgeon design team, 8 surgeons that were a mix of US and international. And we just wanted to create safer instrumentation for hip arthroscopy for the patient, so that we can avoid any iatrogenic scuffs, but also to make the procedure more straightforward for the surgeons performing it. And a lot of what we came up with is really great stuff. And it's a common sense approach to, okay, we have a problem. What is the safest way to address that problem without damaging articular cartilage or injuring the labrum? I worked with ConMed and Smith & Nephew. I'm on a design team with them to create a new hip wand, which unfortunately is paused because of COVID. And a lot of the innovation kind of stopped when COVID happened, and it's starting to get going again. But really the goal with it is to make life easier for the surgeon and for the patient. And if we can cut, what I like to call the pain points of the operation, if we can cut those down to a bare minimum by providing better instrumentation, we can get better outcomes for patients. So that's been kind of my experience with it here, 11 years out from fellowship.
Yeah. So again, I mean, the partnership with industry allows for innovation. You need a John Glenn, you need a pilot to be able to try something new and different. You can't just have the engineers build it and then hope that it works. And then I really enjoyed your language on that, in that, yes, you're spending time out of your busy, world and clinic to develop this instrument, which you should be paid for your time, by the way, because you are doing that. But yet it's a missionary role. You're creating new instruments that make it better for outcomes for the patients to have better, so that synergy and relationship with industry, I think, if handled correctly, is transparent, and open, I think is a great way to sort of push us, into new directions. So let's talk a little about something else, which I think that you're passionate about too, and that's the orthobiologics space. How are you using orthobiologics in your clinical practice, both operative and non-operative?
Yeah, non-operative, I offer PRP to several of my patients. The story behind that's very simple. You and I both know the literature, and it was very, very, hit or miss in the early days. So when my daughter was born, she's 8 years old now. We had her home from the hospital, and I tripped on a toy airplane, and I had her in my left arm. So I fell awkwardly onto my right wrist, and I had a UCL subsheath tear. And so I could barely lift a cup of coffee, scared the daylights out of me. And so one of my hand partners, Crystal, suggested, like, hey, try a PRP shot. And I go, man, the literature's all over the place. I don't think it'll do anything. And so sure enough, firsthand experience made me a believer in it. So I had a total of 3, and that was 8 years ago. So I offer that for both my hip and my shoulder patients. I think it's a powerful non-operative tool, and something that if you're fortunate enough to be a responder to PRP, it can really help you. In the OR, we'll do a smattering of different orthobiologics. We'll do BMAC, we'll do PRP. I do a lot of that for my collegiate Division I athletes, mostly because schools foot in the bill and it's not a huge deal for them. I do a lot of biologic augmentation. So I've used several grafts, acellular dermis being one, rhodium being one, and BioBrace being one. And really, when you think about what Steve Snyder did so many years ago when he introduced this concept of augmentation for rotator cuff and what it did to our outcomes for massive rotator cuffs, that's really what I wanted to do, is apply that same principle to the hip. So it wasn't anything novel or anything special, but it was taking a principle that was proven and applying it to a new world and new space in orthopedics.
Yeah. So again, for our listeners, Judy's listening. So the PRP is the thing when we draw the blood out, we spin it down. There's these growth factors and we inject them. It's super cool. And there's more and more literature and evidence really sort of backing at this point. So I think most doctors have sort of gotten to the point that we're over the hump that PRP has a role in their non-operative practice. There's BMAC, which is bone marrow aspirate concentrate. You pull it out of the hip, they put a needle in, they draw it out. So certainly much easier to do in the operating room than it is in the office setting, although Donnie Buford has a video where he can do it in 20 minutes. And, but that's the Donnie Bufords of the world. And then all these patches, which is super interesting. And Sarab Shah just, published his meta-analysis in the journal of, I think it's ASCS, and looking at implants in the setting of rotator cuff repair, demonstrating that there was significant improvement in healing with these types of implants, whether it's acellular dermis, which was included, whether it's the collagen-based implants, whether it's the collagen structural-based implants. So it'll be interesting what is now sort of still out there, and people like you and I are doing it. Like I just looked at my data for the BioBrace for the rotator cuff. I've got 71 out of 78 of complex rotator cuff repairs, as well as revision rotator cuff repairs that are surviving with this BioBrace implant. That's a really good number for these, complex tear patterns. So anywho, bottom line is that there's a lot of things that we're doing, right, that are going to, sort of evolutionize what we're doing. And the things now where we may have to get prior authorization, maybe one day, you're not going to do a rotator cuff or gluteus medius repair unless you put one of these implants on. We won't pay for it. So I think that it's wonderful to see that you're moving from shoulder back and forth to shoulder and hip, and that really sort of helps us in our science and where we go from here.
Yeah, Scott, it's exactly what you said. It's going to, I believe, become the standard of care one day. What we need to do as, clinician scientists is we need to show, okay, what is the best graft for what situation? Because I can tell you that, we don't walk on our rotator cuff, but we do walk on our gluteus medius. And I think the structural characteristics as well as the physical demands of those tendons have to be addressed in a specific way. And, it's up to us to figure that out for, the rest of orthopedics and the rest of society.
Yeah, no, there's no question about it. I mean, we're doing it a lot better than we used to, right? It used to be all about experience-based medicine, but your generation in particular is really caught up on evidence-based medicine, right? You've got to prove it. You've got to be able to show the data that what you're doing actually works. You can't just say, I'm a nice guy, I drive a nice car, my wife's beautiful, come and I'll operate on you, So maybe we should cut that out, Grace. I don't know. We'll leave it in. But anyhow,
I think leave it in, Scott, because my wife is really beautiful.
All right, I love it. So is mine. So that's awesome. So we're both getting some brownie points there. So but the point is, so let's talk about that. I mean, you're integrally involved in research. You're on the podium. You're trying to really make a difference here and settle the score, what works and what doesn't work. So what drives you and your passion right now when it comes to research?
I mean, I think the big thing is outcomes. I think it's what you said, prove it. We're repairing, gluteal tendons through the scope. Is that superior to doing it open. I just had a debate with Brian Kelly at AOSSM about that. We just had a paper provisionally accepted for publication on endoscopic repair of full thickness 3-tendon retracted hamstring tears. And I can tell you that's a big passion of mine, because we've done up to 15 centimeters retracted, all endoscopically, through 4 or 5 portals. And what a boon that is for your patients, because you're not sitting on a giant T incision. You don't have to worry about those terrible wound complications. The nerves are easy to find, easy to protect. And I think that's what really drives me, is to take these procedures that we've developed and make them now the gold standard of care across the board. But that harkens back to the education. That harkens back to, we need more courses. We need more cadaver labs. We need, people that are like you, that are willing to give their time, for a non-for-profit course to teach others new techniques. And I think that's really the pathway forward, and for both orthopedics and for society as a whole.
Well, it's pretty obviously, why you're sought after. You're incredibly articulate, you're passionate, you're innovative, all of those things in space. So, all right, let me ask you a question. What's the brand for Jovan Laskovski? What is it that you think you want people to know about you, both professionally, from your colleagues, but your patients? What's the brand of Jovan?
Perfect is good enough.
Yeah, that's a good slogan. I like it.
We would say for years, the enemy of good is better, and don't go chase perfect. But I think that if you can strive for what Rob Bell showed me, and Dr. Bird showed me, and Philip Pond showed me, and Kelly showed me, why can't we strive for that? Like every case to be as perfect as humanly possible. We're never going to hit it. We can never be perfect every single day. But if we set ourselves that bar of, hey, we're going to keep going at this until we get this thing down to perfection, then I think that's really, for me, my technical love of orthopedics is working with my hands. I grew up with my dad, who he would never pay anybody to fix anything. He's like, listen, we're going to go get the wrench. We're going to fix this thing. And I get a lot of joy and satisfaction from working with my hands. And I think that's really the thing that I love about my job the most, is the technical side of it. And then also that we've got this silly little tradition in our office. There's a little bell that's hung, and at 6 months, when we discharge somebody post-op and they're doing great, they ding the bell and give me a high five as they go run out of the office. So it's those kind of things that keep you going.
No, I love it. We were just talking about that. We need a cowbell in my office. I do a lot of cow collagen. So I like when they're done. I think it's a great idea. Let them hit the bell. All right. So let's talk a little something about that I'm passionate about, and you are too, which is social media and your brand. So how do your ideal patients find you? What's the path to getting into your office that's most successful?
Siggy, in town, word of mouth, no question. Word of mouth is the best social media, I think, and that's how most people find me. I only do LinkedIn. I don't do Twitter. I don't do any of the other stuff, just because I found it's a giant black hole that can take up your entire day scrolling through. But I do LinkedIn, so that way, my patients out there can see, the professional things that we're up to, and what we're doing to help the world of orthopedics. What's interesting is somehow, some way, somebody posted my name on the posterior hip pain support group on Facebook.
Oh, no, that's not a good thing.
That's not what you want, but it actually has been good, because I've been able to help people. For years, we went down this pathway where it's piriformis, 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 piriformis. And to be honest, I think the number one diagnosis back there is a partial thickness hamstring tear. That's been my experience with it, along with issue femoral impingement. I've seen maybe 7 or 8 real cases of piriformis, but I've got a very skilled radiologist that lives up the street from me, Trisha Delzell, who's a world-renowned MSK radiologist. She really helped me kind of crack that kind of black box that is the posterior hip. And she's phenomenal. So when I get a patient from, let's say, Vermont or Washington or Seattle, wherever it may be, usually we set it up so it's a dual visit. So you fly in, you're going to see Delzell or my partner, Travis Cleland, who does ultrasound for us as well. And then I'll see you for a clinic visit, and we'll put all that puzzle together for you and solve it. So that's been kind of the pathway or the funnel that by which people have found me.
It's interesting, because patients are so much more savvy, and word of mouth doesn't happen just, at church or at work. I mean, word of mouth happens through Facebook and Instagram and these things like you've talked about, where these chat groups or communities that come together. But that word of mouth helps to spread. And the vast majority of patients now are going online and they're checking out your reviews and they want to know who you are and the stuff that
100%.
you're doing, right? So it's probably happening for you by osmosis for a lot of reasons, but it's interesting. We definitely see that a lot. I mean, look, bottom line, Jovan, you're awesome. This is great. I love your energy. I love your passion. I love the fact that you're going to innovate and educate all at the same time, and you're working with industry. You're 11 years in, dude. You got a lot going on. It's good stuff.
I appreciate it, Siggy.
No, it's great. Really. We look forward to. Am I going to see you at OSET? Are you going to be there on Tuesday?
No,
Wednesday?
I won't be. I won't be at OSET. But if anybody's heading to Ish in South Africa, I'll see you there. And then the next meeting after that will be Tel Aviv, the hip, knee, and shoulder meeting out there. So hopefully I can see you at one of those two.
Love that world traveling stuff. That's like that little secret sauce that we don't want to talk about. But like when you get really good at this stuff and you got a niche, and then you get invited, you get to go all over the world. How cool is that?
It's a dream come true, Scott.
Yeah, I love it. I love it. Well, it's been a real pleasure talking to you, Jovan. I look forward to seeing you again at a meeting soon. This is Dr. Scott Sigman, #FollowTheFro, host of The Ortho Show. Till next time.